The patient is a 71-year-old who presented with left lower quadrant pain and bloody diarrhea. And he presented to his primary care physician, and a colonoscopy was ordered to work this up. And he was found to have a mass in the descending colon. His CEA at baseline was 6.0, and he had an excellent performance status and was able to carry on all of his daily activities without assistance. The tumor was biopsied. It showed adenocarcinoma, and full mutational testing was sent, including KRAS, NRAS, BRAF, and he was not shown to have any mutations. CT of the chest, abdomen, and pelvis showed a mass in the descending colon, and he also had 2 lesions in the liver, one in the right lobe and one on the left lobe that was abutting the left hepatic vein. Treatment was initiated with FOLFIRI and bevacizumab, and imaging at 3 and 6 months showed decreased size of the lesions, but they were still not resectable. This is a fairly typical patient with colorectal cancer on multiple points. So first, his age. Colon cancer, the median age is above age 65, depending on what database you look at. So having a 71-year-old is fairly typical. Second, it's left-sided. The majority of colorectal cancers are left-sided tumors. The presentation is fairly typical in the sense that it often presents with abdominal pain and bleeding. And unfortunately, many patients are diagnosed with stage 4 disease, and specifically unresectable, or at least initially unresectable stage 4 disease. So in many ways, this is a very typical patient that any oncologist, whether at an academic center or the community, is going to see commonly in their clinic. So mutational testing for newly diagnosed colorectal cancer is very important. In fact, I would argue you really can't take care of a patient without those testing results. So let's talk about a couple of the things that you look for. So first of all, we need to know RAS status, especially for a left-sided tumor, because you need to know if panitumumab or cetuximab have a role in the care of the patient, and may even be used first line on multiple guidelines, including NCCN. So knowing the mutational status of KRAS and NRAS is extremely important in terms of the choices of chemotherapy. Secondly, BRAF status. So BRAF is also important both for prognosis, because patients with a BRAF mutation don't live as long as patients who are wild type. And secondly, it might determine what type of treatment you use, and in fact, NCCN guidelines are being updated for patients with BRAF mutated colorectal cancer. Third, microsatellite testing, also very important. There's 2 ways of testing for that, and remember, this is basically issues with DNA repair that can either be inherited as an hereditary non-polyposis colorectal cancer, or also called Lynch syndrome, or it can be spontaneous actually in the tumor itself. And for patients who are microsatellite high, if you test by PCR, or if they have deficient mismatch repair, if you test by immunohistochemistry, those patients are eligible to receive immunotherapy. And again, guidelines plus the FDA package insert for several drugs were changed to reflect this. So you really can't take care of a colorectal cancer patient without knowing KRAS and NRAS. And by that I mean extended KRAS and NRAS testing. It used to be we would test codon 12 and 13, and now we know we need to test other codons. You need to know BRAF, and you need to know MSI testing. And although that doesn't have to be back before you start your initial therapy necessarily, you're going to want to get that as early as you can so that you're not scrambling as you're making therapeutic choices.